Welcome to the Agency for Healthcare Research and Quality's webinar for the AHRQ National Webinar on Medication Without Harm, How Digital Healthcare Tools Can Support Providers and Improve Patient Safety. Although few people are still logging in, we're going to get started on time. My name is James Swiger, and I will be moderating today's webinar. I currently serve as a Health Scientist Administrator for AHRQ's Digital Healthcare Research, or DHR program, which is part of the Center for Evidence and Practice Improvement. DHR's mission is to produce and disseminate evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients, clinicians, and health systems. We will discuss 3 of these exciting research projects during today's webinar. Here's the agenda for today's webinar. Please note that we are recording the webinar, and the recording and slides will be available on the DHR website in a few weeks. You will be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters. They include Dr. Samantha Pitts, Dr. Camille Vaughan, and Dr. Jason Adelman. This webinar is accredited by Affinity CE. If you're interested in receiving continuous education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. They will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Drs. Pitts, Vaughan, and Adelman also have no relevant financial interest to disclose. Please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We've reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters during the question and answer Q&A panel located to the right of the PowerPoint slides. Please include the presenter's name or their presentation order number, first, second, or third, with your question. As a reminder, participants are in listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to discuss how an e-prescribing tool can reduce medication discrepancies and improve patient safety by enhancing communication between pharmacists and providers, identify how clinical decision support systems can significantly reduce the prescribing of potentially inappropriate medications to older patients at the time of discharge from the emergency department setting, and 3, explain how outcome measures such as wrong patient retract and reorder measure can be developed and used to detect medication errors in electronic orders. And now it is my pleasure to introduce our first presenter, Dr. Samantha Pitts. Dr. Pitts is an assistant professor in general internal medicine and serves as Associate Vice Chair for Ambulatory Quality and Safety in the Department of Medicine, co-director of the Armstrong Institute of Patient Safety and Quality Leadership Academy, and is the director of the Precision Medicine Center of Excellence for Adult Primary Care. Her research focuses on improving ambulatory patient safety and enabling delivery of these evidence-based interventions for health promotion and disease prevention, diagnosis, and treatment for each patient in primary care, including AHRQ-funded work on electronic communication of prescription discontinuation. And now I would like to turn control over to Dr. Pitts.
Thank you so much for that introduction and for the opportunity to share our work today on electronic communication of prescription discontinuation using CancelRx. The premise of our research is that by optimizing electronic communication of medication discontinuation to pharmacies, we can improve patient safety by reducing medication errors. I'd like to start with a published clinical case that illustrates the importance of communicating medication discontinuation to pharmacies. A 69-year-old woman with a history of epilepsy presented to the emergency department for recurrent falls, gait instability, and emesis during the previous 3 months. A recent hospital admission had failed to uncover a clear cause of her falls, one of which led to an eye laceration and hand fracture that required an inpatient rehabilitation stay. Her seizures were historically well controlled while taking levetiracetam, although phenytoin was added after a seizure. 6 months prior to her admission, her neurologist had discontinued the phenytoin in the electronic health record. However, the patient continued to take phenytoin, which had been dispensed by her pharmacy. She was subsequently confirmed to have phenytoin toxicity as a cause for her symptoms. So today, I will share with you an overview of the CancelRx transaction and the context for our work at Johns Hopkins, present our evaluation of the impact on medication dispensing after discontinuation in our EHR, and discuss implementation questions and challenges. So previous studies have demonstrated that dispensing after discontinuation of medications in the EHR, as in the clinical case, occurs in up to 5% of discontinued medications. E-prescribing is now ubiquitous, but electronic cancellation messaging, or CancelRx, has lagged in its uptake, creating a gap in communication between prescribers and pharmacies. Fortunately, however, CancelRx adoption is increasing, and now an estimated 87% of prescribers and 90% of pharmacies are now enabled on a major health information network. This figure illustrates the flow of information in a CancelRx transaction. So at the top, a clinician discontinues a medication, and in green, the health system EHR initiates a cancellation, which is passed through a health information network and is received by the pharmacy software in blue. At the pharmacy, the medication can be deleted or deactivated if possible, and the pharmacy management software then sends a response back through the health information network to the electronic health record. This is a diagram providing an overview of the context and timeline of CancelRx implementation and evaluation at Johns Hopkins. Prior to 2019, our Johns Hopkins internal pharmacies used separate pharmacy management software distinct from our EHR. As a result, prior to CancelRx implementation, discontinuation of medications within our EHR did not automatically result in electronic communication to our pharmacies, and that similarly occurred with our external pharmacies. During this time, we were thinking about CancelRx implementation and conducted end-to-end testing, a proactive risk assessment, and pilot implementation. This informed our widespread implementation of CancelRx in 2019, which allowed us then to assess our impact on medication dispensing after discontinuation in the EHR using a combination of our EHR and pharmacy management software data. At that time, we also conducted a qualitative evaluation, including examination of the information needs of our pharmacists, which we will discuss today. Finally, in 2022, Johns Hopkins pharmacies converted to use our electronic health record software for the pharmacy management. As a result, CancelRx transactions are now sent to external pharmacies, but no longer used within our health system. During this time, we continued to examine workflows for dose changes of medications, which we'll also discuss. So with that context, I'd like to jump into our evaluation of the impact of CancelRx on medication dispensing after discontinuation in the EHR. We conducted an interrupted time series analysis by identifying medications in the electronic health record that were e-prescribed from a Johns Hopkins ambulatory practice to an internal pharmacy and discontinued during our study period, which was approximately 1 year prior to and 1 year following CancelRx implementation. The discontinued e-prescriptions were then matched to data from our pharmacy management software to determine when the prescriptions were last dispensed, and our primary outcome was dispensing within the 6 months following discontinuation in the EHR. We then conducted a stratified pre-post evaluation to examine variation by pharmacy and pharmaceutical subclass as well. This highlights our main results. On the table to the right, you can see that we had approximately 26,000 to 27,000 e-prescriptions in each time period that were included in our analysis among 10,000 to 11,000 unique patients in each time period. The figure on the left shows our primary outcome, dispensing after discontinuation, measured over time. On the x-axis is the study week, and on the y-axis is the proportion of prescriptions that were dispensed after discontinuation. The dotted line in orange is the week of CancelRx implementation. As you can see, CancelRx implementation was associated with a decrease from approximately 8% down to 1.4% of prescriptions dispensed after discontinuation. Of note, not all these represent medication errors, as there may be duplicate prescriptions at the pharmacy. Most of the remaining dispenses after CancelRx implementation occurred when a CancelRx was not sent due to the system settings. For example, we did not send a CancelRx when the reason for discontinuation was a duplicate prescription. Following CancelRx, there was also decreased variation by medication class in the proportion of prescriptions dispensed after discontinuation. In this figure on the left, on the x-axis are the medication classes, and on the y-axis is the mean proportion of discontinued prescriptions that were dispensed within the following 6 months. In blue at the top are the individual estimates by pharmaceutical class before CancelRx implementation, which range from a high of approximately 12% on the left to a low of 4% on the right. And in green are the estimates after CancelRx implementation, which are in the 1 to 3% range. The greatest reductions appear to be in the medications on the left of the figure, which includes chronic medications, which are some of the highest risk for adverse events. Following CancelRx implementation, there was also a decreased variation by pharmacy in the proportion of prescriptions dispensed after discontinuation. In this figure, on the x-axis are the individual pharmacies labeled A through K, and on the y-axis is the mean proportion of discontinued prescriptions that were dispensed. In blue again at the top are the estimates by pharmacy prior to CancelRx implementation with their 95% confidence intervals. And again, you see a range of 12 to 13% on the left down to 4%. And in green below are the estimates following CancelRx implementation, which are reduced to 1 to 2%. So now I'd like to review some of the implementation questions and challenges. First, I will review what we learned from our pharmacists and their information needs when responding to the CancelRx message. To understand the information needed by our pharmacy colleagues when managing CancelRx transactions, we conducted interviews with 11 pharmacists and pharmacy technicians in 3 of our pharmacies and recruited them as a convenient sample. These were transcribed and coded using inductive thematic analysis to examine their information needs. From these interviews, we learned that pharmacy staff often sought additional information following a CancelRx to ensure the correct medication was dispensed to the patient and to provide patients with information and counseling about their medication changes. We identified 3 types of related information, including the prescriber intent or the intended outcome for a medication, whether this was to discontinue it altogether without replacement, to adjust the dose, or to provide an alternate therapy when the medication was discontinued, as well as to understand the intended medication regimen following the CancelRx transaction, including all of the medications the patient should be taking. Finally, the clinical rationale for the medication change, such as an adverse drug reaction, a dose adjustment, such as to improve hypertension or blood pressure control. So I'll share an exemplar passage for each of these. In this passage, a pharmacist describes the challenge of understanding why they're receiving a CancelRx message and the prescriber's intent. So when cancellations do come down, there's no info attached to it. So when a cancellation comes from Epic, or AHR, it doesn't tell you why it was canceled or what's going on. Then it gets into, are we inpatient and we're just clearing the medication list to reorder, or are we really canceling it? Recognizing that there are multiple reasons why they could receive a CancelRx message, the pharmacist sought to confirm that the prescriber intended to discontinue the medication to inform their actions and next steps. In the second passage, a pharmacy technician describes questions about the medication regimen after a CancelRx. Well, if they cancel this medication, are you sending another medication for them, or will you be taking them off that medication? And has this been communicated to the patient as well? That's usually on the pharmacist's end, but I know on the pharmacy tech end, we usually encounter that when we're at the register and they're physically coming to pick up. We found that both pharmacists and pharmacy technicians fielded questions from patients about changes in their regimens and sought additional information to be able to understand questions and answer them, and in the case of pharmacists, to provide additional counseling. In this final passage, one pharmacist eloquently describes the importance of understanding the clinical rationale. It's so important to understand, especially for our critically ill patients, why we're doing what we're doing, because they're going to ask us. And if we don't have that information at the fingertips, we're going to struggle, waste their time, not understand. And then the end result could be, I'm not sure why the physician changed your dose. I don't see it in the notes clearly why they have done this. From this analysis, we concluded that providing additional information to pharmacy staff would improve communication and counseling following medication changes. Ideally, the system could provide sufficient information through the CancelRx transaction to support decision-making. The codified reason for discontinuation will be included in the next version of the CancelRx standard, which will start to provide some greater context and information for pharmacy recipients. This analysis was limited to a small sample of pharmacy staff and pharmacists within our health system. I'd next like to turn to two decisions in implementation in the electronic health record that we encountered during implementation: management of reordered medications and identification of the CancelRx status. In our health system implementation, one question was whether to send or not send a CancelRx when a medication was reordered. As a detail, in our EHR, a reorder discontinues the existing prescription and generates a replacement. In favor of sending a CancelRx is reduction in duplicate active prescriptions at the pharmacy. This also maintains the one-to-one match of an e-prescription with the CancelRx message. In addition, prescribers may make changes in a prescription using the reorder functionality, so it is a safety feature to be able to have a prior dose discontinued during this transaction. However, it does result in an increase in volume of transactions at the pharmacy, which may be perceived as noise and result in additional work. An implementation challenge for us was how the system provides the user with the CancelRx status. Providers want to be able to see the outcome of the prescription discontinuation, at least in some circumstances, to determine that it is successfully canceled at the pharmacy. Ideally, this would occur in real time and in their active workspace, such as in the medication list, or readily accessible and apparent when the information is needed. This would guide any next steps, for example, calling the pharmacy if needed, and also help providers or prescribers understand the functionality of CancelRx. So finally, I'll transition to 3 additional use cases for consideration, which raise questions for thought and discussion rather than having definitive answers. The first is a temporary hold, which was identified particularly at hospital discharge. So when a medication is intended to be discontinued for a short period of time, or a quote-unquote hold, discontinuing the medication in the electronic health record will ensure that the medication list and patient instructions are correct. If a CancelRx is sent and patients then resume the medication as expected, they will need a new prescription, however. So the question arises, how should we best manage a temporary hold of a medication, like a discontinuation with a CancelRx or not? The next case is medication dose adjustments. Some high-risk medications need frequent dose adjustments, such as warfarin, insulin, and immunosuppressants. Patients may not need a new prescription, however, particularly when they have a supply. However, having the correct instructions on the medication is important to ensure proper self-administration. In our experience, we identified that provider workflows may vary as to how they change the dose within the EHR, and this may or may not result in a CancelRx, depending on the workflow and configuration of the EHR. As an example, we've discussed that Hopkins does not have a cancel Rx transaction sent when the reorder is identified as the reason for the change. However, providers may use the reorder transaction and still can edit the medication instructions to make a change in the medication dose or directions. In addition, providers may have additional workflows to document the dose adjustment in the EHR without notifying the pharmacy. So there's still an opportunity to identify the best process for communicating these frequent dose adjustments. Finally, medications prescribed outside of the local provider EHR, for example, those reconciled from an outside electronic health record or patient reported, do not result in a cancel Rx transaction when they're discontinued. Prescribers may not be aware of the distinction between these medications in the EHR and therefore not take additional action when needed. And this may impact some settings more than others. For example, in emergency departments where patients may be receiving most of their medications from outside of the health system. So in summary, Cancel Rx implementation was associated with reduced pharmacy dispensing of medications after discontinuation in the electronic health record, confirming that it's an important tool for medication safety. However, there are still opportunities to address questions and challenges that arose during implementation, including meeting pharmacy information needs, optimizing implementation in the EHR, and addressing the use cases that we mentioned. So I'd like to acknowledge the many people who contributed to this work and thank AHRQ for the support of this work as well. Finally, here is my contact information. I welcome your emails and look forward to your questions later in the session. Thank you.
Thank you, Dr. Pitts. As a reminder, we will be taking questions after all presentations. So please submit any questions you have using the question and answer panel. Dr. Pitts, could you go to the next slide? All right, next up, let's move on to our second webinar presentation, which is being led by Dr. Camille Vaughan. Dr. Vaughan is an associate professor and division director in the Emory University Department of Medicine, Division of Geriatrics and Gerontology. She is a joint appointment as the Atlanta Site Director for the Department of Veterans Affairs, Birmingham, Atlanta, Geriatric Research, Education, and Clinical Center. As a geriatrician and clinical investigator, she focuses on optimizing the care of older adults with multiple chronic conditions. Current projects involve improving emergency department care for older people, evaluating behavioral therapy for treatment of common urinary symptoms in persons with Parkinson's disease, and testing virtual delivery of evidence-based treatment and prevention strategies for common geriatric conditions such as incontinence and falls. And now allow me to turn control over to Dr. Vaughan. Thank you.
Thank you very much. It's a pleasure to be here this afternoon, and thanks to AHRQ for the opportunity to talk about our project. This is, we'll be discussing scaling the equipped medication safety program, traditional and hub and spoke implementation models. So equipped, which stands for enhancing quality of prescribing practices for older adults discharged from the emergency department, implements clinical decision support strategies, as well as audit and feedback for prescribers to ultimately affect prescribing behavior, and has been shown in multiple settings to reduce the prescribing of potentially inappropriate medications to older adults who are at the time of discharge from the emergency department. And we use the American Geriatric Society Beers criteria to help give feedback to prescribers about their prescribing safety and quality. So EQUIPPED actually first started in the Department of Veterans Affairs, initially at the Atlanta VA, as well as the Durham VA and the Tennessee Valley VA located in Nashville. And I will tell you first a little bit just about what the program components are, and then we really appreciate the support of AHRQ and other health system partners, where we've been able to look at how best to export this program outside of the VA setting. And so our project that we'll talk about, funded by AHRQ, was an implementation project looking at different strategies for implementing the program. at several sites between 2019 and 2021. And you'll notice with that time frame that we had some unexpected challenges during that time frame, particularly for the ED setting of care. So as of 2019, this is pre-pandemic, and I think we're going to be getting back to some idea of what kind of usual ED kind of care utilization is in the coming years as we've kind of moved through the COVID-19 pandemic. But prior to that, about a third of adults 75 and older visited an emergency department in the year 2019, and about a quarter of adults 65 and older. So we're seeing more and more older adults that are going to be receiving care in the emergency department setting as that population grows. The majority, though, are going to be discharged from the ED. So they're going to be treated for a condition and then sent back to home or the place that they came from. And at that time of prescribing, up to half or so will receive a new prescription. And that timing of seeing an emergency department provider, someone who's just meeting them at that day, who may not be as familiar with all of the other medications or chronic conditions that they are being cared for, could be a time of vulnerability in kind of the prescribing decision making, particularly for older people. At the time that Equipped kind of initially started, and then as it has grown and kind of expanded over the last decade or so, we also noted alignment of the Equipped program with other initiatives that have been occurring in kind of the United States healthcare system, really focused on promoting age-friendly care, as well as the emergence of geriatric EDs. And there's actually an accreditation process now through the American College of Emergency Physicians for emergency departments that really implement specific strategies to optimize care for older adults in the emergency department setting. And so I think it's been important for us as we try to expand Equipped and increase uptake to also align with these other initiatives so that health systems kind of have a win-win when they're deciding to implement Equipped. So for instance, in the age-friendly health systems movement, this 4M's framework that really starts with the foundation of what matters to older people as they're making decisions about their health care, and then focuses on the importance of the interacting kind of effects of medication choices, mentation or mind, which can include not only cognitive effects, but also risk for delirium, for instance, in older adults, and then mobility and fall risk, and how all of these things really can intersect as we're trying to take care of an older person in kind of a way that promotes what matters to them. Similarly, in the geriatric emergency department kind of accreditation process, there are several pathways to optimize medication use as part of these guidelines, and Equipped can be a way that an ED can begin that journey toward geriatric ED accreditation. This just gives you an idea of a map of the sites nationally that have implemented Equipped. We've had 20 VA emergency departments fully implement or be in process of implementing the program, and then 5 non-VA health systems. And our AHRQ project today that we'll talk about, again, will be related to some of the non-VA health systems that have implemented Equipped. We've also seen multiples of these sites go toward that geriatric ED accreditation process that we wanted to highlight as well. So the overall goal for Equipped sites is to reduce the proportion of potentially inappropriate medications, and again, that's according to the American Geriatric Society BEERS criteria, which are used by multiple agencies to look at prescribing safety and quality toward older adults, to try to reduce that percentage of prescriptions that are considered PIMS, potentially inappropriate medications, at the time of ED discharge toward older people to 5% or less. Now, that target was selected based on looking at the time at Medicare star ratings for the outpatient setting, which might be more aligned with a discharge kind of event from the ED, as well as looking at some of the baseline data from some of our early sites and what we thought was achievable. And to date, there is no specified target for ED discharge prescribing specifically, but I think you'll see in the data that we do, this seems to be a reasonable target for sites. The implementation of Equipped involves 3 core components. First, of course, is education, letting the provider group know about the program, make sure they're familiar with the BEERS criteria, and to let them know about some of the tools that are going to be implemented at their site to try to assist them in making safe prescribing decisions. We do include order sets, which make it faster and easier in the workflow for the discharge prescribing process for a provider to choose a safer option for an older adult. Sometimes those also include some just-in-time clinical kind of decision support with whether if they're prescribing certain pain medications, maybe a bowel regimen, some things that they want to avoid prescribing at all, or even behavioral-based strategies that might be an alternative to drug-based treatment. And then the real, probably most powerful part of Equipped seems to be the audit and feedback reports that are given to prescribers. And we generally, in the kind of traditional way of implementing Equipped, have had those delivered at least once in person by a colleague in the emergency department. So it is done through a strategy called academic detailing, where a peer in the same prescribing environment provides that feedback to the provider individually and allows it to be tailored somewhat to their own prescribing choices. This audit and feedback is delivered at least monthly for 12 months during Equipped implementation. And after that, it's up to the champion to decide kind of what's needed going forward. This just gives you an example of what one of the site's equipped order sets looks like. This is a fairly comprehensive order sets from our New Orleans VA site. And you'll see that there is some overlap. So this is done by kind of conditions so that there's some duplication across different types of settings. So whether it's, under pulmonary, you might see upper respiratory infection. You're also going to see that under the antibiotics menu. So it's about 15 order sets that the sites have to choose from. We've asked generally that an equipped site choose at least 3 so that as we begin to give feedback to prescribers about their prescribing choices, they also have, again, tools at their disposal to help them with those decisions. And we're not just giving them feedback on something without some resources available as well. The sites, though, can choose what they think would be most useful for their site. We often will also give them some information about baseline prescribing rates of PIMS for their local environment so that they can kind of tailor those order sets to kind of the greatest areas of need if they're going to not do as comprehensive a set. And this just gives you an idea of what the order sets might look like in other electronic health records. So we have implemented Equipped now in Epic health record systems. This gives you an idea of kind of the pain medication order set, which generally is one of our more popular order sets across Equipped sites. And you'll just see here how there's some recommendations of medications to avoid completely, some dosing recommendations. For instance, opiates are not on the Beers criteria. We certainly want to reduce how many of those might be given if that is the selected medication, but this also kind of prioritizes a small number of pills, and it aligns with opiate prescribing guidance for the emergency department setting. Then you'll also see there's prompting there for the prescriber to consider a bowel regimen, which would be really important. This is another order set from the Cerner or Power Chart electronic health record. This particular site noted at their baseline data that they had a lot of prescribing of musculoskeletal relaxants. It's a common class among our equipped sites, I'll say, from the ED discharge environment. They actually decided to prompt prescribing of a musculoskeletal relaxant that's not on the Beers criteria. We don't necessarily encourage that, but this is something that site decided would be important, again, to just limit the number of pills in particular. So it just gives you an idea that there is some adaptation that the site can do to tailor the order sets for their particular environment. So now I'm going to walk you through the AHRQ supported project that looked at 2 different strategies for implementing Equipped. One where it was kind of this traditional model where you had a very engaged champion that was really involved in order set implementation, providing the education for the provider group, as well as delivering that audit and feedback with academic detailing. And then another kind of hub and spoke model where a site that was within a health system that had multiple emergency department locations at different hospitals within that same health system, where the hub site was that first site that had implemented Equipped, and then they were basically able to kind of offload some of those champion tasks at the other sites because they could turn on some of the Equipped components more easily. So again, this just summarizes kind of the difference in kind of that hub and spoke model versus kind of the traditional implementation strategy for Equipped. Again, our traditional site was also a Cerner Power Chart site, so it was a new AHR at that time. And then our spread sites, again, we're all using the Epic health record. And so basically some of the things were streamlined in that health system because at other Equipped sites that were implementing the program, they could basically just turn on the order sets. They were already developed. They didn't have to do that from scratch. And the education could be delivered by already identified champions from the prior implementation process. For equipped, those who receive the audit and feedback reports, because there is some flex in the provider group over time, we generally focus on full-time providers. That could be physicians, advanced practice providers for that hospital. So if they happen to have people who are moonlighting, for instance, or resident trainees, we don't provide the feedback reports necessarily for those folks that are kind of coming in and out of the ED. We're focused primarily on those who are there all the time. Now, when we look at the overall prescribing rates, it's all prescriptions written in the ED. So it does, there might be some people who had access to certain components of Equipped without that audit and feedback potentially. And this again just summarizes that difference between the traditional site and then the hub and spoke model. Now the equipped program team, which includes some coaching from people like myself who have helped other sites implement equipped multiple times, that was available for both of those implementation strategies. When we look at the effectiveness evaluation for equipped, we evaluate that in a few different ways that will show you those results. We certainly are looking at the overall PEM prescribing rate. We evaluate that using Poisson regression because of the counts that we're looking at in those evaluations. And then we'll also show you some of the results also in an interrupted time series model that gives you some idea of how things change during that kind of baseline period before equipped began, the intervention phase, and then post-implementation. And for that baseline versus post-implementation evaluation of equipped, we do look at a 12-month period before and a 12-month period after implementation to try to give some time frames that are similar. For this project, we were very fortunate to partner with an implementation scientist, Michelle Kegler, who's based at Emory in our School of Public Health. And we used the REAIM framework for the overall evaluation of the program with components of the Consolidated Framework for Implementation Research, which was developed within the VA system to really understand some of the implementation facilitators and barriers. And for this project, again, looking at 2 different implementation strategies, that was really important. Some of the different measures beyond the prescribing rates that we looked at included looking at the time to implement all components of the equipped program, the education, the order sets or clinical decision support, as well as that audit and feedback with at least 1 in-person session for all the prescribers. And that was evaluated by looking at meeting minutes from those local teams with the equipped kind of coaching team based at Emory. And then we also had our implementation evaluation team conducted focus groups with our traditional site, as well as interviews with implementation team members across those spoke sites at the hub and spoke model to get additional kind of qualitative evaluation. So our idea was that the hub and spoke model would accelerate implementation. It would make it easier to launch equipped, but that we would hopefully see similar reductions in those potentially inappropriate medication proportions as we would observe at kind of the more traditional type of implementation that we had done previously. This gives you some idea of the baseline characteristics of our site. So our traditional site was located in the southeastern United States in a large metro area. And then our spread sites that were affiliated with that hub were located in northeastern United States. And for the first time, actually, in our equipped implementation across, again, VA and non-VA sites, we actually had a community hospital. So traditionally, these early adopters of equipped had often been affiliated with an academic health system. And so we were excited to also kind of see how does the program do in a site that may not have as much of that kind of academic kind of influence as well. So in looking at the PEM prescribing results across sites, we were really delighted to see that all sites achieved a significant reduction in potentially inappropriate medication prescribing across the period of evaluation for the equipped program. You'll see that if you're thinking about that 5% target, not everybody got to that 5% mark. But we also noted that particularly with some of the sites that were not as academic affiliated, not as tightly academically affiliated, we saw higher prescribing rates of PEMs at baseline than we had seen at some of our previous sites. So we generally had, kind of anywhere from 7% to 10 or 11% at baseline. And we actually, one of our sites, up 16% of the prescriptions being ordered at discharge were considered potentially inappropriate. So while we didn't quite get everyone to that 5% mark during that time frame, it was really amazing, and particularly if you think about what was happening in EDs during this time frame with the COVID pandemic, that they had significant and substantial reductions. We also saw certain classes that particularly seemed to improve. Musculoskeletal relaxants were generally across all sites reduced, and then some sites had some, depended on the site. Benzodiazepines sometimes were reduced, or antihistamines depending on the location. And this just gives you those same results looking at kind of that time series model, so you kind of see across the 12 months before equipped, 12 months post intervention, and there was about a 12-month phase in between as well. And this gives you those interrupted time series as well, so you can see. So, with any quality improvement project, we get a little worried about kind of the drift back. And I do think you get a sense, maybe it spread site 3 even more a little bit, but the good news is really mostly sustained change. And this is what we've seen at a lot of equipped sites. It really seems to influence potential for culture change regarding prescribing toward older people. Now, our other area of interest was looking at how easy it was to implement, how fast did it happen. There we did not see the kind of speeding, the kind of increasing or kind of making it a little more facilitated to implement equipped for that hub and spoke model. Now, it's hard to say how much, certainly the COVID-19 pandemic influenced it. And frankly, we were just amazed at all of the sites that they really had a fairly brief pause around March 2020 and then picked right back up with their audit and feedback back in June of 2020. So really heroic efforts by these sites. And we did get some information from our qualitative evaluation that suggested that because the, one of the spoke sites said equipped was really handed to them on a platter. So maybe because it was a little easier, they didn't have to do as much as far as figuring out how to get order sets implemented at their sites. Maybe they just didn't have quite as much buy-in for kind of even tailoring that feedback to their prescribers or kind of getting kind of that audit and feedback going. Whereas our traditional site was really in, our champion there was really in the weeds, had to figure out committee structures to get order sets implemented. And while that barrier of doing the prescribing feedback, was there as well, they found it a little easier even to tailor some of the feedback because they were so familiar with what was happening locally. So we conclude from this implementation evaluation that certainly equipped seems to be very well tailored to the busy emergency department environment as a medication safety program. Certainly all sites, despite the disruptions of the COVID-19 pandemic, were able to implement the program, which I think speaks to being very well tailored to the needs of clinicians in that environment. But that, and that we saw, reductions in PIM prescribing, maybe not getting to that target of 5% or less that we were hoping for, but certainly substantial reductions in PIM prescribing. So that for sites that maybe don't have as many of those personnel resources, the hub and spoke model could be reasonable. But it still seems that probably the most effect of the program may be for those sites where you have that kind of local engagement of that champion that's really kind of shepherding the program from beginning to end. And with any of these projects, it's huge amounts of effort from folks to facilitate it. And we just say thank you to all of them. And we'll look forward to questions later. Here's my contact info. Thank you.
All right. Well, thank you, Dr. Vaughan. And again, please feel free to submit any questions that you have during in the Q&A panel at this time. All right, so moving on to our final presentation of this webinar, which is being led by Dr. Jason Adelman. Dr. Adelman is the Associate Dean for Quality and Patient Safety, Director of the Center for Patient Safety Science, and the Associate Professor of Medicine and Biomedical Informatics at Columbia University Irving Medical Center. As a Program Director of the Patient Safety Research Fellowship funded by AHRQ, Dr. Adelman mentors fellows in projects addressing many of the challenges facing hospitalized patients today, including sepsis, hospital-acquired infections, and also medication errors. Dr. Adelman was named one of the leading national patient safety experts by Becker's Hospital Review multiple times between 2017 and 2023, and in 2022 was the recipient of the John M. Eisenberg Patient Safety and Quality Award for Individual Lifetime Achievement from the Joint Commission. And now I would like to turn control over to Dr. Adelman.
Thank you. Good afternoon, everybody. I'm going to be talking to you about using automated measures to improve patient safety in healthcare. And I'm going to start with a case example. This is a real case, some details modified to protect those involved. Forgive me for reading. This case involved Mrs. X. She was an 87-year-old female who was admitted to a telemetry unit with a diagnosis of rapid atrial fibrillation. A day after she was admitted, a first-year medicine resident accidentally placed an order for methadone, 70 milligrams for Mrs. X, which he had meant to order for another patient. And for those who don't know, methadone is a powerful narcotic that we use to help those addicted to heroin come off of heroin. Both of these patients, Mrs. X and the intended patient, were on the resident's patient list and the electronic health record. Several hours after Mrs. X received the medication, she was observed to be restless, complaining of being hot and nauseous, and shortly after, she was found unresponsive, pulseless, with blue extremities. A code was called. She was intubated and transferred to the ICU. This is an example of a real wrong patient error with an order being placed on the wrong patient by accident. It turns out I found this article. This is from 1820, so over 200 years ago. It's from the London Gazette, and they had said, having another patient of the same name in the hospital whose complaint was violent spasms and flatulence of the stomach, the prussic acid was by mistake administered to the wrong patient, a circumstance highly credible to the apothecary and by no means uncommon in London hospitals. And so you can see we've been struggling with wrong patient errors for over 200 years. When I first started working on orders placed on the wrong patient, I was investigating what those before me had studied and why these errors happen. And one of the leading explanations were what were called juxtaposition errors. It's the kind of error that happens when there are two names on a patient's on a resident's list, and you need to click on one and click on the other. And so in my work in trying to prevent wrong patient errors, we realized we really needed a measure to evaluate any interventions we wanted to study. And so we came up with this automated measure of orders placed on the wrong patient. It's was really quite simple but very effective, and it's illustrated here. We created this measure that looked for when a provider placed an order or several orders on patient A, and within 10 minutes cancel those orders after placing them. And the very next thing the provider would do is place the exact same orders on a different patient, patient B. The data scientist I worked with when developing the measure used to call it the oops query, like, oops, I'm on the wrong patient, let me cancel it and reorder it. We now call it the retract and reorder measure. And we, at the first institution where we created this, there were over 7,000 in 1 year. So many that we were able to call within real time, just an hour or two after one of these events happened, and ask the provider if in fact this retract and order event was a wrong patient error. And 170 confirmed it was, 76.2%. We've since redone it, and now it's over 80% confirmed that the retract and order events are wrong patient errors. And when I had initially looked at when we call people and we ask them, was it a wrong patient error? For those that confirmed it was, we then asked them why the order was placed on the wrong patient. And the prior research, as I shared, showed that the leading thought was they were due to juxtaposition errors. But we found only 10% of the people we interviewed said that they placed an order on the wrong patient because of juxtaposition errors. 80% said it was really interruption. They would tell the same story over and over again. I'm admitting Mr. A. I'm ordering his medications, lab tests, imaging tests. And in the middle of all this work, I get a call that Mr. B is in pain. Can I order Percocet? So I switched to Mr. B and I ordered the Percocet, and that's when I get interrupted. I have a 5-minute conversation with a colleague, and then I go finish Mr. A's admission. But I forgot that for a moment I switched to Mr. B to order the Percocet. So the rest of Mr. A's orders go to Mr. B. It's just we keep too much in our working memory, and with multitasking and interruptions, that was the leading cause that we found of orders placed on the wrong patient. This measure, automated measure for wrong patient errors, was the first health IT safety measure endorsed by NQF. And we used it to study multiple things. So we're just completing a study now funded by AHRQ, evaluating if photos of patients can help prevent orders on the wrong patient. And the results look very positive, but I'm not quite ready to share them yet. We had done another study showing it was shared by the neonatologist that often in the neonatal ICU, patients would have, there'll be many wrong patient errors. Using the automated wrong patient retracted order measure, we were able to confirm they were right, that there was more wrong patient errors in the NICU compared to general pediatrics. And it was largely believed to be for the problem you see on the screen, that often when parents have their children and they don't necessarily have the name ready to go right at birth. So hospitals would name children baby boy, baby girl temporarily. And for those admitted to the NICU, this is like a real screenshot. You'd have baby boy Jones, baby boy Johnson, baby boy Jackson. We had used the automated measure to show if you change the names from baby boy, baby girl to using the mother's first name, Mary's girl, Linda's girl, Yvonne's girl, you could really reduce wrong patient errors. We published this in Pediatrics and showed almost a 40% reduction by using the mother's name. And then that led to the Joint Commission making it a requirement, a patient safety goal, that you can no longer use baby boy or baby girl as temporary names for newborns. And so we had actually done a survey when we first started this. It was through the American Academy of Pediatrics. About 40% of the NICUs responded, and 82% said they were using like baby boy, baby girl, or BBBG. And after our paper was published, we repeated the survey 5 years later, and it went from 82% down to 70%. And I'll tell you, 5 years has since passed. We repeated the survey one more time, but now the Joint Commission made it a requirement that you can't use baby boy, baby girl. And we're just analyzing the data now, but as perhaps it's not a major surprise that the Joint Commission was very effective in almost eliminating the use of baby boy, baby girl. Even though if you use the mother's first name, like if you see here on the bottom, Judy's boy Johnson, Judy's boy 1, Judy's boy 2, this is representing twins. At Columbia, where I work, 40% of the children in the neonatal ICU are twins or triplets, and they have near identical names, near identical medical record numbers. This really seemed like a problem, even with the safer naming convention. So we looked at that using the same automated measure of wrong patient errors, and it turned out it was exactly that twins had double the wrong patient errors of singletons, and triplets and high order multiples had double that of twins. For the exact reason that you would think, if you looked at a pair of twins, any one of the children would have the same wrong patient error rate as other children in the NICU, except that they had all these errors with their sibling, and that's how they got to double the rate, the confusion between the siblings. And so similar to our photo study, we have another grant that's studying what we call pictographs. We didn't think that photos necessarily of these babies would help prevent wrong patient errors. So with our grant, we had a professional artist draw hundreds of these pictures, and then the mom is given an app. She chooses, let's say, the purple dinosaur, and then that gets checked out. So there's only one purple dinosaur in the NICU at a time, or here's a blue whale. And so instead of a picture of a patient, you see a blue whale, and very soon after, the nurses and the providers know which child is the blue whale versus the purple dinosaur. We're still evaluating. The study is still going on. when we first started the study, I got a call from the chief operating officer of the Children's Hospital that Columbia was expecting quintuplets for the first time in 20 years. And we weren't fully ready to start, but we were able to, just for the quintuplets, get them all pictographs, put them in the electronic health record. I also spoke to the mom when she was still pregnant and asked if she had the names ready to go, and she did. And so instead, they were going to be baby 1, 2, 3, 4, and 5, and instead they were, as you can see here, it just so happened this happened right around Mother's Day, so it became a Mother's Day story in the New York Post. And we got little onesies made for them, so you can see their pictographs, and this was their name in the record at the bedside, Sebastian, Sophia. We actually, and I'm happy to say there were no wrong patient errors, no retract and reorder events. Another study also funded by AHRQ, as I got into the space of working on wrong patient errors, I would often hear or get questions about my thoughts of, is it safe to allow multiple records open in the electronic health record, like you see here, like opening multiple browsers at the same time? And there was, we had done a survey to see what was the practice before applying for the grant, so we could see how much there was a need to really have this question answered. And interestingly, about 42% of the people that responded, the institutions that responded, allowed the maximum number of records open, and 41% restricted to one. And then the rest sort of hedged in between. And literally those that locked it down said, we had a couple wrong patient errors. We think it's because multiple records open, so we restricted to one. And those that allowed multiple records open said, providers need to multitask, so we leave them open. And those that split in between said in their comments that we're trying to balance the risk of wrong patient errors and the need to multitask. So using our automated measure, we randomized providers in one institution. Half were allowed to open the maximum number of records, which was 4, and the other half were restricted to just 1. I'll tell you that before we did our study, based on expert opinion but no evidence, ONC and the Joint Commission were recommending limiting to 1. There was just a feeling that it was a problem. But our study that we published in JAMA showed there really was no difference wherever we looked overall, in the emergency room, inpatient. In the emergency room, where providers often multitask, the odds ratio between the two groups was literally 1.00. The P was 0.96. There really was no difference. These studies would not have been possible without an automated measure of wrong patient errors. We couldn't do the photo study, the pictograph study, this study. We needed a large number of automated errors that were reliable. Voluntary reporting is too biased. Chart review, not everybody writes that they placed an order of the wrong patient in the record, and it's very labor intensive. So these automated measures really made this research possible. We then realized that we can make more of these automated measures with the general concept of somebody places an order in the electronic health record and then cancels that order shortly thereafter within 30 minutes, there's a good chance that they canceled it because there was an error. And if we see what they did next, we may be able to isolate the specific type of error, make a specific measure, and then use that measure to study interventions to try to prevent the errors. So imagine instead of placing a couple orders on patient A, canceling it, and then ordering it on patient B, what if I ordered morphine 5 milligrams on patient A, canceled it, and then ordered morphine 1 milligram back on patient A? So I don't change the patient, I keep the patient the same, but I change the dose. Or I can change the route from IV to oral, or the frequency from twice a day to 3 times a day. And so that's exactly what we did. We got another grant from AHRQ to make and validate these measures. And so to set the stage for you, and our organization is 21 million orders placed a year. 385,000 are canceled within 30 minutes. 112,000, they're canceled and then reordered with some element changed. If you look at just medications, there's 85,567 medications that are ordered, canceled, and then reordered with one element changed. And so this is the same number here, the 85,567. 20,000 times they changed the dose, 12,000 the frequency, 5,000 the route, and so on. And so we did the same thing. We made phone calls, and we're just finalizing and publishing now, writing our articles. But 76% had said that they confirmed that it was in fact a wrong dosing error, 87% wrong frequency, 85% wrong route. And so when we have these measures finalized, then we can start study interventions to try to prevent these errors, as we did with the wrong patient error research. One of the things that we also did is we made this automated system for calling people in real time after they make an event. So if you take the wrong dose measure, we run our query using live data every 30 minutes. And if the computer program picks up an event where somebody placed an order, canceled, changed the dose, it takes elements of that event. Who was the patient? Who was the provider? What was the initial dose? What was the new dose? It puts it all in a Qualtrics survey, like an electronic survey tool, with some survey questions that we pre-specified, puts it in an email and automatically sends it to our research team. And then a research assistant calls and asks the ordering provider within an hour or two, excuse me, doctor, with permission, IRB approval, can we ask a couple questions? And then we interview them, confirm if it was a dosing error or not. If it was not, why did our measure not work? And more often it is. And then once we confirm it, we ask follow-up questions of what led to the dosing error. So we can really try to understand why people make wrong dose errors, wrong route errors, wrong frequency errors, and then maybe that information, which is in real time, an hour or two after they made the event, can inform some decision support or intervention to prevent the errors. We use a general taxonomy when we interviewed people, like at the highest level, we looked at mistakes, which are the provider actually has the wrong plan in their head. They have the wrong dose in their head, as opposed to skill-based errors where they have the right plan in their head initially, but somehow they, click on the wrong thing, or they have a slip or a lapse along the way. And although they start with the right idea, they wind up with the wrong idea and make the error. And then there are further classifications after that, but I find this the most interesting, and I'll show you. So for wrong patient, 96.8% of all the people we called, they had said that it was more like a slip or a lapse. They started off knowing who they wanted, but along the way they got largely interrupted and they got confused and wound up on the wrong patient. Where dosing errors, they actually have the wrong dose in their head to begin with. They didn't realize it was a drug that needs to be adjusted for the patient's weight or for renal function. And so now with these measures, we haven't done it yet, but we can look at, they're very reliable automated measures. There's no reporting bias because we're sort of capturing it with real data. We can look to see if doctors get tired at night. Do they make more errors? And are they more likely to make wrong patient errors, which are more execution errors, or wrong dose errors, which are more like knowledge planning errors? Or if you compare attendings to first-year interns, we can really start evaluating the differences in the mechanisms of errors and how they affect different cohorts at different times. So in summary, we came up with this methodology of creating automated measures. We call them retractable order measures. They make research that was previously not possible. We can do these outcome measures like randomized evaluations of photos, of pictographs, of multiple records open, of how we name babies, and soon how we try to prevent dosing errors. And we'll have reliable measures and enough power to do these studies. Also, it makes it possible to make real-time phone calls to interview people and learn why errors happen to inform decision support and interventions. And so we've made some additional measures now, but there are more that we can make and beyond the ones we made. We're finishing up wrong dose, wrong frequency, wrong route, and there's the potential to go in make more medications, go in other domains. I just want to end by, I do, as in my introduction, I'm the PI of a T32 fellowship program funded by AHRQ, where we train physicians to be patient safety researchers. And there's a little code there that you can scan or reach out if you have any junior faculty, graduating residents who might be interested in doing some patient safety research with us. They can certainly reach out. So thank you. Look forward to your questions.
All right. Well, thank you very much, Dr. Adelman, and thank you everyone for all of, big thank you to all of our presenters for the very informative presentations today. As a reminder, please submit any questions you have for any of our presenters using the Q&A panel to the right. This concludes the content portion of the webinar, and we do have some time for some questions, so let's get into those. You can type them into the Q&A section, as we noted, into the WebEx portal. And if we do not have time to get to all the questions today, we will provide responses to all of them in writing, and you will receive an email once these responses are available. So if everyone's ready, let's get started with a few questions. The first one I'd like to ask is actually for Dr. Pitts. So Dr. Pitts, this is from someone in the audience. They enjoyed your presentation. And there was some interesting variation among the 6 to 8 pharmacies in the rate of prescribing after receiving the Cancel Rx order. Did you identify any characteristic differences between those pharmacies which might have contributed to the variation?
Thank you for that question. It's a very interesting question, and I would say that analysis where we looked before and after with both pharmacy and the pharmaceutical class was somewhat exploratory and hypothesis generating. So we didn't drill down to examine those characteristic differences. Again, that's also, we looked by a single characteristic. So there may be some relationship between the types of medications that are more frequently dispensed in the pharmacies as well. So it's a great question and something that's worth future consideration. Thank you.
Thank you very much. Next question I have is for Dr. Vaughan. I think at some point in your presentation, you talked about the platter of feedbacks, and that made me think of how receptive were clinicians in the ED to those individual prescribing feedback elements. What additional thoughts do you have on that?
Yeah, thanks so much for that question. I think in general, we've found prescribers to be really take this feedback with an open mind and generally have very little pushback. And I think there's a couple of factors that help. I mean, one is that, again, generally that feedback's being delivered by a colleague that they trust and know. And they also know that person's kind of practicing in the same setting they are, which I think also kind of helps with acceptance. We have not advocated like a lot of public shaming, or strategies like that. Like we don't put people's name up on a board as you enter the ED or something like that, where they're kind of so, and so when they get like even they do receive peer benchmarking at many of the sites. It's done anonymously, so they're not seeing how they're doing they're seeing how they're doing compared to their peers, but they don't know exactly who the others are besides their own. So I think those are things that help with uptake. It's not a punitive type feedback. It's really done in the setting of like, we all want to do the best we can by our patients, kind of approaching it as an opportunity for improvement. And then also I think the openness of, I'm prescribing in the same place you are. So if, others in the prescribing environment are able to kind of make choices that are considered safer, what can we do together to kind of make that, kind of easier in your workflow? You get always, there's occasional folks who give some pushback, but we've also tried to help champions. That's one of our coaching strategies with some evidence-based information for those occasional kind of pushback on like, well, why is this particular medication a real problem? I've been prescribing it for years type thing too.
Thank you for that answer. So next question I have is, Dr. Adelman, I'm wondering, do you have any recommendations for institutions that are facing implementation challenges, particularly around taking and storing of patient photographs in their EHR?
Yeah, I can. We're just finishing up our analysis, and we'll be publishing soon. But uh, it seems quite clear that photos help prevent orders on the wrong patient, and so I strongly endorse that practice and helps in the every clinical setting we look at inpatient, outpatient, ED. Um, we currently at New York Presbyterian have over 1.5 million photos in our um, system, and when I started, we had zero. We it How you can get photos in the HR may be vendor dependent, but we had a multi-pronged approach. We worked with our registers to take them on entry points. We also use kiosks to register, and we facilitated photo capture there. Even for those on Epic, Epic has an app that patients can use, and they can take their own photos. So we used a multi-pronged strategy. It's really just getting leadership buy-in, a real commitment, and putting some effort into it. And then you can do it. Right now, about 80% of our patients in the hospital have a photo. It's definitely doable.
All right, well, that's great. Thank you. Um, Dr. Pitts, did your study include quantifying safety events as a result of dispensing discontinued medications prior to the Cancel Rx implementation?
Thank you. That's a great question. And it really ties in, I think, to the work of Dr. Adelman, which is how you identify those without medical record review in some feasible way. So we did not. We came what we thought was close, a step before, which was really dispensing, but didn't examine the safety events, mostly because it's hard to measure. And we have things like event reports and whatnot, but we don't think are an effective strategy for measurement. So that's some of the challenge of this, and I think a great area to continue to work.
Thank you. I have another question for Dr. Adelman. When you when you did your call to the prescriber and asked them about the type of drug error, what were common explanations um, from them whereby you didn't count it as an error per se?
Um, Thank you for that question. So there are several categories in that area. So most were errors, but if new information happened to present itself right after the order was placed, so you place an order and then you find out the patient has a low blood pressure that you didn't know when you placed the order, so then you canceled it. Or um, we Another example is, imagine if you ordered 3 units of insulin for a patient and canceled it and then ordered 30. That would be a very dramatic difference, and very often that would be errors. But if you ordered 30 units of insulin and canceled it and ordered 31, it's a very subtle difference, and it's very hard. There's no standard that says 30 is right and 31 is wrong. It's more like the art of medicine than an error. And so when providers describe situations that were just so subtle, you could see them more. There's no subtlety in being on the wrong patient, but there is opportunity for subtlety in like dosing. And that's just two examples.
Thank you. And while I have your thoughts on that, we have two related questions to kind of your approach with the retract and reorder. One is related to following up with survey questions and analytics. Is it done in a separate system or is it integrated into the EHR? And a separate question is, how did you arrive at the 30-minute cutoff for the RER measure?
The system that we use to make phone calls, we pull data out of the EHR and then um, have like a C# program that runs and uses Qualtrics. It's sort of a pulling from a couple of different systems and bringing them all together to make our automatic phone call system. It's not doesn't live directly in the electronic health record. And the 30 minutes, was derived from some prior research from Ross Capel and others, from are looking at the data like um, through a histogram of when orders were canceled, um, and a combination of those things. And we came up with a 30-minute cutoff. Um, Although it may be that there are, like Ross Capel showed, there are errors that happen at 45 minutes or 2 hours, but sometimes the further you go out, the more errors you can capture, but the positive predictive value goes down. And so there's a trade-off between the number of errors you capture and how good the positive predictive value is. And you want a good positive predictive value for an automated measure. And at some point, if you have 15,000 errors, you might be able to get 17,000 if you change the time a little bit, but it's not very meaningful. 50,000 is more than enough to do the studies we want to, and so that kind of approach.
Okay, that's very interesting. Thank you. I want to go back to Dr. Vaughan's presentation for a moment. One of the things, in kind of looking at and evaluating how the work was done, was the team able to assess how frequently the order sets were used?
And that's a great question, and we commonly kind of get that question from, particularly from sites that are considering the program. One of the interesting things about, and not every site has been able to gather that level of data, but several have. So when we've been able to gather that data, one of the interesting things we find is that if you just look at quantitative assessment of like clicks on the order set to actually order the drug, prescription, to input the prescription, it's a lot lower and less frequent than we would think, given the enthusiasm often for the order sets at the implementing sites. So this is where this kind of mixed methods evaluation has been very helpful, because when we actually talk to prescribers at those sites and ask them about their knowledge, awareness of the order sets and how they've used the order sets, we actually found there's a substantial number that are what we call consultant users. So basically they look at the order set and they internalize what is being recommended, what drugs are being recommended, frequency, and then they go ahead and order those drugs through their own ordering process that they kind of already have, ironed out for their own workflow. And so if we really only looked at those quantitative clicks on the order set, we really would be missing a substantial amount of the use of those order sets by this kind of group that we kind of termed consultant users. So I think that's a really important question. I do think the order sets are often a piece that the health systems are, at least the champions are really interested in kind of having some tools at their fingertips. And we might have decided they weren't that important if we only looked at clicks on the order set. So just encouraging folks to use those kind of mixed methods approaches.
Got it. Thank you very much. As a reminder, if anyone else has any additional questions, feel free to add them in the Q&A section. We have a few more minutes. So I do want to go back and ask another question of Dr. Pitts. With your approaches, have you assessed CancelRx's impact on clinical workflows and how that's integrated?
Yes, that's partly what we did as part of our AHRQ-funded work, was to interview different stakeholders and conduct observations with both the pharmacists, with prescribers, and then also with patients. So I do see there is a question in the chat too about what if the patient has the med in hand? So maybe we can get back to that. So absolutely, that was one of the concerns, and I think is still an area where more work needs to be done in terms of making decisions about implementation and understanding both how the prescriber identifies the outcome of the transaction, for example, and then how that informs their next steps, as well as how the pharmacists respond. And in some systems, more or less work is automated in response to CancelRx. So there is a lot of variation probably out there in understanding how to optimize those workflows. Probably requires additional study in different environments, but is really important. Just to touch on the issue of the patients, we did the interviews with patients, and Amanda, you're absolutely right that if the patient already has the medication, communicating with the pharmacy is not sufficient. And so an additional gap we identified was really describing to patients also disposal information and what to do when they do have a medication in hand that that they should no longer be taking. So that was another area, just to recognize that it won't solve all problems, but as a contributing piece. So thank you.
Thank you. And Dr. Adelman, one final thought. I'm curious what other types of measures could actually help to identify electronic ordering errors. What other thoughts do you have on that topic?
There is, as I shared, like over 360,000 orders placed in my organization that were canceled within 30 minutes. We called just those without the full retraction or just the retraction, and about 80% said they were errors. And we worked out the measure for wrong patient, which is 10,000 of the 360,000, and dosing for 20,000. There's hundreds of thousands left. You can order CT of the head with contrast, cancel it, and then order without contrast. Order an ankle X-ray, the left ankle, cancel, and then order the right ankle. This, I think pretty much any order that can be placed in error. And when we see it canceled, it's a good sign that it was an error. And if we see what happens next, we may be able to isolate it, figure out the measure, and then work on the problem to solve it and use the measure to evaluate the intervention.
Thank you. So again, if anyone else has any other questions to add, I do want to ask one final, just kind of a general sense from the group, and then I think we will move into kind of final closeout comments and reminders about CE credits. I'm curious if the panel, given your research and focusing on safety and using digital healthcare tools, I'm wondering if each of you could just share any thoughts around potential research gaps or even how artificial intelligence or where we're transitioning to gaps that perhaps AHRQ could focus on, or even other researchers as we kind of enter this new territory within healthcare. So I guess Dr. Pitts, if you want to go first.
Yeah, wow. There's a lot, there's so much around the AI and the buzz. Yeah, I'm not sure about the AI connection, but I do think about how other systems are in place in other areas internationally around medications and technology and doing cross comparisons. I have seen some of that work, but that's, I think, really interesting to think about what different technologies are in place to support our care teams as one thought. And then I'll turn it over to others and see if I have other thoughts. I'll jump back in.
Sure. Dr. Vaughan, do you want to go next?
Yeah, I mean, I'll say I do think that sometimes I'm amazed at how I just browse something on the internet and it pops up in several social media feeds immediately, that there's so much integration across other, kind of commercial settings, and we haven't seen quite as, just, I think we're just on the cusp of what's possible kind of in healthcare. I'll say for the Equipped project, one of the areas that we saw kind of an opportunity and is getting there is about renal dosing of medications, particularly for older people. Declines in kidney function are very common, and often a prescriber might get a pop-up alert that tells them the creatinine clearance, but that requires them to not just dismiss the alert, which is what we actually avoid alerts in our program. That was a lot of feedback. It was like, please don't give me another actionable alert. I would love to have a better integration where the with the prescribers trying to order a medication, the EHR is able to actually propose dosing based on that patient's creatinine clearance, for instance, might be one strategy. Right now, a prescriber, if they notice that, would need to go back out, then look it up, figure out what they need to adjust to. That's some of you probably saw in our order set example we did try to do with a couple of the medications just to make it, to quick order even, but they still have to know what the patient's creatinine clearance is, even for that. So, I mean, that's a simple thing that I would love to see. We've talked about that with some of our really bright engineering students, to try to come up with a strategy. It's just not as easy as you would think, it seems, but I think we'll get there. But that's like a quick example that we've thought about.
Yeah, that's very true. And Dr. Adelman, any thoughts on your end?
Yeah. Um, just in the last 2 years, David Bates published an article in the New England Journal that I'm sure everybody saw about the current state of safety in the hospitals. And the Office of Inspector General put out a report around the same time. And both reports remarkably showed that about 25% of admitted patients have adverse events, with the general theme that since the era is human in the last 25 years, we just really haven't made all that much improvement in patient safety. I personally think that it's a very exciting time for those of us that do research in patient safety because of AI. We all have our smartphones, and smartphones are 90% made by computers and robotics and 10% humans slapping the pieces together at the end. But healthcare is still 99% humans, and humans just make errors and just culture. And so AI, finally, we can have a computer tapping us humans on the shoulder and say, wait, are you sure you want to order that now? Or, hey, you forgot the EKG. I was very excited to see just in the last few days that AHRQ had a funding announcement for AI. And my vote is more of that. That's, to me, is the big hope that will finally break the back of this problem of patient safety.
Very true. And of course, that is why we do what we do in digital healthcare research. And you're absolutely right. We do have that funding opportunity out. So I encourage everyone to take a look at that and that opportunity. Amal, if you could go to the next slide, I think we can close out and some of our final CME credits. So first, I want to thank our panelists. I mean, it was a delight to sit and chat with you and also learn from your expertise and everything. And of course, all of our attendees, thank you for attending today and supporting AHRQ and the work that we're doing as well. For those of you interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on the slide, hitwebinar.cds.affinitysced.com, and you will select today's webinar, which will be indicated by the date and title to claim your credits. You have 14 days to claim your continuing education credits. Also, upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we very much would appreciate that you will complete the survey and share your feedback with us. And with that, I thank everyone and have a great rest of your day. Thank you.